Why it is called as irreversible means if once the cell get dead or injured, it will never get reversed. So it is called as irreversible ischemical cell death. Okay. Then the functional changes are
losses of contractility, and there will be a reduced cardiac output and electrical instability, which leads to an arrhythmias. There will be a possible heart failure or cardiogenic shock.
Few minutes. Here majorly we concentrate for LV contractility. So once if LV get myocardial cell get death or necrosis means it will affect the LV contractility, that is loss of contractility. If contractility get once affected, it will lead to sudden loss of cardiac output. So reduced cardiac output. Reduced cardiac output or reduced movement in LV can cause skipped beat or arrhythmias, that is electrical instability, and possible heart failure, that is cardiogenic shock also will be happened again. And sometimes it will lead to same as like congestive heart failure or sudden arrest or sudden collapse at all. So the symptoms for myocardial infarctions are,
there will be two types of symptoms, okay, which is one is typical and another one is atypical. Let's see about the typical symptoms. There will be a severe central chest pain, okay, and pushing and heavy chest discomfort, okay, and there will be pain radiating to left arm, jaw and neck, okay, and back. There will be sweating, shortness of breath, nausea and vomiting, which is common, and there will be palpitation and anxiety.
Once if it is typical means which will lead to showing the symptoms like severe chest pain, palpitation, crushing pain, which is a patient can't able to explain how it is lost or how it will be like. Then palpitations also. Another one is atypical, which is epigastric comfort. Earlier typical means which will leads extended to the neck, jaw, left arm, left shoulder, back pain, everything. But here atypical means it is only common in elderly women or diabetic people. Not much more pain get focused. Here epigastric discomfort, fatigue, dizziness, and sometimes syncope and mild breathlessness. Okay, without the chest pain.
Let's see about the diagnosis of the myocardial infarction.
Mostly we will diagnose using ECG, and second thing is echo, and third thing is laboratory, and fourth is cardiac catheterization level. Here the ECG are which artery get occluded, that placement of artery will show the
correlation between the ECG and echo, that is STEMI, which is here the ECG shows that ST elevation, that is echo typically confirm that corresponding to RWMA, ST depression and ST elevation. So good concordance, which one is a culprit artery through the echo better predict the actual myocardial involvement. And in NSTEMI, the ECG may show the ST depression, that is T wave inversion. Echo often shows that changes in ST depression linked to more to diastolic dysfunction also. Here the T wave inversion to the systolic impairment and regional issues. So the old infractions can mimic the acute one on the echo, thin scarred walls versus normal thickened walls. An ECG may be a non-diagnostic tool, that is where echo
ST segment elevation and necrosis means ST segment depression along with the elevations due to the Q wave changes at all. And in echocardiography we can learn or we can understand that instability or poor contraction of LV and low cardiac output which get measured during a mode or apical 4 chamber, 2 chamber at all. Also strain method will be there for understanding what are the walls get affected, that is akinetic or dyskinetic or hypokinetic at all. Then next thing is about laboratory preparation, which will lead to enzymatic changes like troponin Ti and troponin T, a cardiac marker. Then the fourth one is called as cardiac catheterization. Initially we do diagnostic level, that is artery. By passing the catheters, we can know about which is get occluded or necrosed. Once if it is occluded 90%, it will leads to necrosis of LV. So if it is 90% occlusion, will leads. Next step is we want to do PTCA, that is placement of stent in the occluded area. That is about coronary angiography.